Well, hello, my name is Lindsay Pratt, and I am a PA. I practice at University of Colorado School of Medicine in the Department of Hepatology and Liver Transplant. And I've been practicing for 15 years. I started my career in private practice, gastroenterology, and for the past 13 years, I've been doing hepatology and liver transplant. And happy to be with you here today to discuss MASLD and MASH and the use of non-invasive testing techniques. So we're going to talk about this common clinical scenario where we have discordant results between a test such as a FIB4 and vibration-controlled transient elastography or FibroScan. So why can we have these discordant results? So I think we first need to think about what are the components of the test. So in the case of the FIB4, if you think about what's in the numerator of that equation, it's the patient's age and the AST. So we know that the FIB4 at extremes of age greater than 65 is sort of the cutoff where that test could give you a sort of falsely elevated value, and you need to take that into context or use a higher cutoff like 2 for a patient greater than 65. Conversely, if a patient's under 35, the test doesn't perform as well. If the patient, for example, has an elevated AST level from inflammation, so either from MASH or from recent alcohol use, then that could also elevate your FIB4 score. And elevated transaminases don't necessarily mean that they have advanced fibrosis. And then if we think about what's in the denominator of the test, the patient's platelet count. So, if you have a patient with thrombocytopenia, you'd be worried about more advanced fibrosis and developing portal hypertension. But you want to consider the patient might have a low platelet count from other causes. Maybe they have ITP or they're on a medication such as immunosuppressant that's causing thrombocytopenia. So those are things that can cause your FIB4 test to be either kind of falsely elevated or falsely low. And then moving on to VCTE or FibroScan. So there's a number of things, another variables that can confound the results of this test. So first of all, the patient needs to be fasting for 3 hours prior to the test. And we always counsel patients when they're scheduled for FibroScan that they need to fast. But if a patient is not fasting prior to the test, then that can falsely elevate their liver stiffness measurement. And there have been studies looking at this, that if a patient ate before a FibroScan, it could elevate their reading by up to 25%, which is significant. We know that the FibroScan is less reliable in a patient with a BMI greater than 35, which of course is not uncommon in the MASLD MASH patient population. Inflammation, as evidenced by elevated transaminases, so ALT, AST greater than 100, certainly you want to consider whether or not the FibroScan is the right test or interpret the results accordingly. So inflammation from MASH, from alcohol use, or another process could affect the outcome of the test. And then also there's the potential for just operator inexperience or variability. So you want to make sure whoever is doing these FibroScans has been adequately trained. They know how to place the probe in the patient and how to get at least 10 consistent readings with it. So that's kind of the reasons why you can have discordant values between, say, your FIB4 and your FibroScan. What do we do with that? When I'm faced with a patient where, the blood work doesn't necessarily line up with the FibroScan. So let's say that we have a patient with an elevated FibroScan reading suggesting more advanced fibrosis, but their labs really aren't consistent with advanced fibrosis or developing portal hypertension. They have a normal platelet count, normal liver function. And let's say we have an ultrasound that shows a relatively normal appearing liver. There's no evidence of a nodular liver or splenomegaly or anything else that would have you concerned that they have more advanced fibrosis or portal hypertension. I would want to do a secondary test in this case. So MRE or MR elastography is probably the gold standard for non-invasive testing. It does evaluate the whole liver, and it's not as sensitive to some of these confounding variables like the FibroScan would be. Limitations with getting an MRE on everyone is, of course, insurance coverage. You need to think about if it's a patient who is obese, especially their BMI is greater than 40, are they going to be comfortable or is it going to be feasible for them to have the MRE? And then just making sure that if there aren't any other contraindications, like if they have any implants that are not MRI compatible, or that they don't have iron overload or anything else that could affect your results. And then I still, we do a fair amount of liver biopsies still in our clinic. I mean, I think it's still the gold standard for staging fibrosis. I mean, even though we have all these other tests that hopefully we can use to non-invasively stage fibrosis, if I have a patient that I have any concern for a competing etiology for their elevated liver enzymes, such as autoimmune hepatitis, if their liver enzymes are higher than what I would expect for just MASH alone, I might want to do a liver biopsy. And I think it's also nice if you end up doing a liver biopsy and it correlates well with your fibroscan, then you can use your fibroscan going forward to stage fibrosis pretty reliably. But I think at the end of the day, you have to consider the patient in front of you. I mean, we have all these algorithms, but you got to go back and look at the patient. Is this somebody that, based on their history, you're really concerned that they might really have, in fact, advanced fibrosis? Do they have a long-standing history of poorly controlled diabetes, or a family history of MASH cirrhosis, contributing alcohol use? Do their labs or their imaging have you more concerned for advanced fibrosis or cirrhosis? Always come back to the patient and make the decision based on that. So how do I explain to the patient when results are discordant? I try to explain to them before I even do one of these tests how the test works, what components go into it, and why a test might come out inaccurate for them. So if I have a patient, for example, with really elevated liver enzymes, but we're going to do a fibroscan rather, I'll caution them that, if their ALT is greater than 80, we're going to have to take the results with a grain of salt. And if it comes back with a low fibrosis score, then it's really, we can rely on it to exclude advanced fibrosis. But if it comes back with an elevated liver stiffness measurement, then we might need to consider secondary testing. And then I would give them the option of either doing something like an ELF score, or doing an MRE or a biopsy, or even just a fibroscan 6 months down the line to just kind of see longitudinally, are those tests consistent. But I think just explaining to the patient what goes into the test, what could potentially affect the results, and then, explaining to them what the options are for more secondary sophisticated testing, what that entails, and what's just, the best in terms of their care. Thank you for listening today. And if you have any questions about MASLD, MASH, how to use this non-invasive testing, please feel free to reach out to me. I'd love to hear from you. Thank you.